Hello, my name is Judith Fulton. I'm presenting my graduate project for Nursing 695, Dr. Pho Thai, for October 28, 2017. This is my certificate of original authorship. The facility, the target population, and the background. The overall project was to develop and implement and evaluate a unit of nursing content, lecture handouts, test questions to be delivered in the associate degree RN classroom, attend clinical and participate in the simulation lab experiences, and create a simulation. My practicum took place at ECPI Charlotte campus. Monica Pfeiffer was the director of the program, and my mentor was Cheryl Carlin, MSN, RN, experienced educator with a wide array of experiences in teaching with a focused practice background in emergency medical nursing. Background for the project is as we approach a time of anticipated shortfalls in nurse practitioners, it is important that we prepare each student and faculty member with evidence-based practices, and this occurs through didactic, hands-on simulation, and clinical experiences. By participating in these during my practicum, I was afforded the opportunity to experience the clinical instructor's role in various settings, including didactic, lecture, simulation, and the clinical setting, as well as writing NCLEX questions. The test questions arose primarily from the textbook and Aspiring Minds as a resource, which is how to create and test blueprint. For the simulation, practice, and rehearsal are two of the primary teaching strategies used for novice students in all settings. They expose the student to skills and behaviors that not only allows, but encourage them to grow and develop skills in a safe environment. This allows the student to cultivate technical skills without having the distraction of time and distraction of the background data. As they progress from the limited and inflexible, rule-guided novice stage into other strategies, they may be utilized for assessment and intervention. My graduate project only required one simulation, but after speaking and collaborating with Professor Pfeiffer, the director of the program, we decided in creating an evolving simulation that would be a tool that would be utilized at ECPI Charlotte, but I focused on simulation 4 out of those for my graduate project. Special permissions for project approval. Professor Pfeiffer, the director of the program, approved me completing my graduate project at ECPI Charlotte. She also approved or provided approval for Professor Carlin to be my mentor. The final approval, I did not require any approval for adaptation of my project because I held to the one simulation for the ECPI Virginia Beach graduate project while implementing and creating an evolving simulation as a way of thanking ECPI Charlotte for allowing me to complete my practicum on their campus. Graduate project at a glance. It included classroom instruction, NCLEX test questions, which there were 10 that I was required to do. Classroom instruction was an hour and a half of a lecture, including artifacts, which were handouts, which were part of the original PowerPoint presentation, evaluation tools, and the didactic. The NCLEX questions arose from that presentation. And then finally, simulation, which we've already discussed, which was an evolving simulation, which incorporated or included 6 simulations that were created with all of the artifacts, as well as the number 4 simulation, which was utilized for my graduate project, which was a cumulative simulation, including patient report and change in status related to a diabetic crisis. The setting and the audience. The site was ECPI Charlotte campus, which is a one building facility that houses multiple associate programs as well as the BS programs. There were 16 BSN students in the group that I work with. They were in their final clinical rotation prior to Dimensions course. The age range was 20 to 58 years old, primarily female, white, non-Hispanic, 3 African-American students, 2 Caucasian males, 3 Latino American students, and 8 Caucasian female students. All learners were employed either full or part-time, and all or half of them worked in some form of healthcare prior to entering the program. The stroke or didactic portion of my project covered part of the curriculum. The overall goal was for learners to gain knowledge necessary to identify risk factors, appropriate interventions necessary to plan and provide nursing care for the acute and rehabilitative care of a patient experiencing stroke. The presentation was done on 8/14/17 from 09 o'clock to 10:30 a.m., which included pre-assessment and care map, which completed out the evaluation of the presentation. The discussion or prep for the presentation began 2 to 3 weeks prior when we selected stroke as my portion of the curriculum to present. At that same time, I began working on the questions that would be utilized to evaluate the students' understanding and completion of the stroke portion of their curriculum or didactic coursework. And this was also the time that was utilized for the NCLEX questions. The focus was on risk factors, modifiable versus non-modifiable, review, management, and treatment options, acute versus long-term care of the patient, and the progression of disease. I opted to utilize a basic presentation structure that is familiar to the learners. After many hours of observing and interacting with the students, it became clear that they prefer to follow an expected routine. They can be flexible and are open to new experiences, but during high stress times, pre and post exams, I have observed anxiety levels that are brimming to overflowing. I recognize that the students were preparing for their final class while also preparing for the state licensure exam. Recognize that these two large changes to their routine might negate, or any large changes might negate any learning that could occur during that anxiety and that may arise from a drastic change. Led me to utilize the format that the students were accustomed to. The typical format for the students' didactic instruction is PowerPoint and other resources uploaded into the Moodle in the learning management system prior to class. This allows students an opportunity to acquire the basic knowledge necessary to meet the goals and objectives for the class. The in-class preparation or presentation provided a platform for clarification, reiteration, highlighting specific information. It also provided an opportunity to perform an informal pre-assessment, formative assessment, and summative assessment. The assessments allow for real-time evaluation of students' understanding, which in turn provide an opportunity for in-the-moment clarification or further instruction or explanation of specific information. Due to the time frame and not being able to see them prior to the exam, it was best to use internal assessments as well as post assessments, which included the care map that the group did as a group. And it allowed me an opportunity to evaluate their understanding of the data. Evaluation. The day of the presentation, the class opted to complete a collaborative care map for closing out. The final step provided immediate feedback and an opportunity for clarification. It was also ideal because I would not have the opportunity, as said previously, to review with them prior to the exam. Prior to coming in, it was obvious by the questions leading into the lecture that the students had read or previewed the data that had been provided for them for the lecture. Interim, during the presentation, some of the NCLEX prep questions were embedded into the PowerPoint. So we could do in the moment or assessment of their understanding of the data that was being shared. And also allowed for clarification. Post-assessment, there again was the care map. The group did it collectively and allowed for them to discuss as peers their understanding and give feedback to one another, as well as allow me to assess their understanding. Care map was a cumulative or final review that day to assess their understanding, and they were able to process from beginning to end the signs and symptoms, the emergent care, and the follow-up care of a patient experienced strokes. The exam, the 10 NCLEX form test questions were utilized for the student's unit and course unit and course assessment. Adapt. In the future, when I lecture, I will use more slides and fewer items on each slide. Best practices have shown that there should be no more than 5, max 6 items on a slide. And also, you should have one primary item on a slide at a time, using darker backgrounds instead of bright white, and fade out each item as you discuss it, so the attention will be drawn to that one item during discussion. This has been implemented in this presentation, and I will use it in future presentations for lecture. Breaks. Watching the body language of the students and implementing breaks as needed, and also embedding them about every 15 to 20 minutes during a lecture. Shorter, more frequent breaks rather than one long break in the middle of the lecture would be more effective in keeping the students attuned to the presentation. Care map versus case scenario. In this instance, I chose care map because I needed immediate feedback from the students. Case scenarios are best, I believe, if you allow them time individually, collectively to work post-lecture. And that requires more time for the immediacy of the lecture at hand. The care map was the best tool for the review. Case scenarios can always be added as a follow-up to cement or solidify the discussion or didactic portion of the course. NCLEX test questions, as stated earlier, these were started or initiated 2 weeks prior to presenting the stroke presentation. After acknowledging or identifying what I would lecture on, I began preparing NCLEX level questions. They were reviewed by Professor Carlin on at least 2 occasions. She provided feedback, and the questions were revamped or reworded to assure that they were meeting the requirements of the students and the outcomes. Writing the test questions should be built on a plan and step-by-step procedure to assure that they are following a specific or following the specific guidelines and using a blueprint. Implementing, there again, the questions are given to students to be evaluated once they've been reworded and prepared to assure that they're similar length, the responses are of similar length, the verbiage is the same, there are not any errors in the questions, and they're at the appropriate level, assessment level or application level. Evaluating the test questions was daunting because of the number of participants, because of the low number of respondents. it was very difficult, or there was inability to prove stability with the questions. Evidence-based or best practices say there should be at least 100 respondents to identify questions or tests as stable. So we would need to pose those questions to at least 85 more participants prior to giving true statistical feedback on the questions and changing them accordingly. The statistical results did show the test questions, tracking of the questions over time would provide the necessary information to determine if the questions were effective and appropriate. With available data, 4 of the questions tested well and would be considered appropriate if results were found to be the same with sufficient respondents. 3 of the questions utilized appeared to be too difficult. The remaining questions would be considered too difficult if the respondents were of a sufficient number. Before altering the questions, I would test the questions again and possibly augment the areas of the presentation that were stressed. Adaptation. Simple adaptation for the questions. There again, I would re-implement and pose the questions to several more respondents prior to augmenting them. I would focus on assuring or stressing various points in the lecture rather than alter the questions at this time. Summative evaluation has all been touched upon. Is the final exam was utilized for summative. The Eberly Center for Teaching Excellence includes written exams as examples of summative assessments. The exam schedule for the unit utilized test questions that were created specifically to assess knowledge and outcomes related to stroke. The questions were in line with the curriculum as well as with the testing body's guidelines for NCLEX. Professor Carlin once again reviewed the test questions and they were revamped according to her directives. CareMap. CareMap was an effective tool and would be utilized frequently in the future as far as evaluating student knowledge and understanding of a topic. Again, I would assess the students closer to evaluate their attention span and need for breaks during lecture. Simulation. Simulation was the final portion of my program focus. Program requirements were that I do 1 simulation, singular curriculum focused on a specific topic, specific area. Facility interest, there was a gap here because the campus was looking at revamping their curriculum and utilizing more simulations. And the idea of creating and implementing an involving simulation that would be utilized throughout their experience at ECPI came into play. I collaborated with the OBGYN nurse specialist, critical care nurse specialist to help create the individual simulations. There were a total of 6 simulations. The 4th, which was diabetic crisis and patient report, were provided or utilized for my graduate project. The evolving simulation notebook was created and presented to ECPI staff. It has been reviewed and there are plans to utilize it for ongoing education with future students. Participant review. The students reviewed the simulation utilizing evaluation tools that were created by me, and as well as an evaluation tool that was provided for the preceptor. The students' responses were positive. Students did state that they had not participated in a scenario that was as involved prior to simulation 4. The focus had previously been on one specific task. The students stated that the scenario was realistic and challenged them to consider the whole picture. The students' realization that the healthcare professionals can and do make errors was eye-opening, and they understood that it takes a team to work together for the best outcomes of the patient. Instructor review, Professor Carlin reviewed or utilized the evaluation tool and selected all exceeds expectations as far as her evaluation. So we will continue utilizing the simulation as it was created. Pre-simulation, I would provide more time for the students to review the resources that were provided. Due to time challenges, the simulation time was cut short. We were expecting 2 hours, but we had a little over an hour, almost an hour and a half, to do pre-work, the simulation, and then post-simulation. And it is true, and evidence has shown it is through the remediation or post-simulation that the wealth of simulation knowledge occurs. Interim, the students were able to work through the process. They understood it. They worked together as a team, and their cohorts that were observers were able to make note of the strengths of the individual students and utilize those in post-simulation conference. Finally, closing out, I would like to say, just as this cartoon or meme symbolizes, thanks to global warming, that stupid bear will never get us way out here. The miracle of adaptation. Not only the students, but we as healthcare professionals and educators must adapt. We must meet the students wherever they are. It is not for them to seek us out at all times, but we have to prepare them. But as they become more immersed and more knowledgeable and more prepared, they can meet us where we're at. It is our drive to initially go where they're at and pull them and push them and encourage them to a greater understanding. And that means us learning and continually seeking new ways of reaching them.